Let's now look at the clinical features of atrial fibrillation. To start with, the symptoms of atrial fibrillation are present with a wide array of symptoms. Majority are asymptomatic. Remember, in majority of the patients, around 85 to 90% of the patients, atrial fibrillation may be asymptomatic. Palpitations, dyspnea, fatigue, dizziness and angina may be the features. Decompensate heart failure may be the presenting feature in people who have associated heart failure due to atrial fibrillation. Patients do complain of polyuria. This is because of increase in the atrial natriuretic peptide, otherwise known as the BNP. In addition, atrial fibrillation can be associated with hemodynamic instability or hemodynamic dysfunction and congestive heart failure. Or the patient may suffer what is called tachycardia induced cardiomyopathy, which is a very serious condition. The third associated feature could be systemic thromboembolism because of the blood stasis in the atria and then formation of clot which get dislodged and then enter the systemic and pulmonary circuit. So, the associated things could be hemodynamic dysfunction, congestive heart failure, tachycardia induced cardiomyopathy and systemic or pulmonary thromboembolism. The clinical signs of atrial fibrillation are as follows: irregular heartbeat, the pulse apex disparate, that means there will not be any synchrony between the pulse and the apical thrust. Patient may or may not have tachycardia. Usually they have some degree of tachycardia, but if the AV nodal conduction is much slowed down, then they may have even bradycardia. It depends on the AV nodal conduction of the impulses. Variable intensity of the first heart sound. This is because of the irregular ventricular contractions and the lack of atrial activity. Occasional S3 may be heard, but S4 is always absent in all cases because S4 sound is again due to the atrial activity and we do not have a good atrial activity in atrial fibrillation. So, S4 is absent. Absence of A waves in the jugular venous pulse. The A waves are again atrial waves. So, because the atrial contraction is not taking place, the JVP A waves are absent. We have to look for signs of underlying heart disease like rheumatic heart disease, coronary artery disease, hypertrophic cardiomyopathy, dilated cardiomyopathy, the HCM and DCM, and look for cardiac failure and atrial embolization into systemic and pulmonary circuits. Patient may have an associated WPW syndrome and ventricular rate in that case will be definitely more than 200 and may prove fatal. Normally the QRS is narrow and narrow QRS tachycardia is seen. Sometimes it may be wide QRS tachycardia, sometimes there may be bradycardia because of block at the AV node. So, these are some of the clinical signs of atrial fibrillation. The age of the patient has got a very strong relation to the outcome of atrial fibrillation or to the onset of atrial fibrillation. Look here in this slide, people who are less than 60 years of age, only 1% of them suffer from atrial fibrillation. In people who are between 60 and 79 years of age, 4% of them suffer from atrial fibrillation. Once the patients are older than 80 years, then the rate of atrial fibrillation is 8%. So, from 1% in less than 60s to 8% in 80 plus age group, it is a very significant trend of the relationship of age and atrial fibrillation. The same thing holds good for the complications too. The thromboembolic complications of atrial fibrillation are also associated very strongly with increasing age. Let us now look at some of the causes of atrial fibrillation. In this country, in all tropical countries, particularly in India, the leading cause of atrial fibrillation is of course rheumatic valvular heart disease. Whereas in the Western world, rheumatic valvular heart disease is not the first cause of atrial fibrillation, is not the most important one of atrial fibrillation. For us, of course, rheumatic valvular heart disease nonetheless is still very much there with us, and we have atrial fibrillation due to RVHT. The other cardiometabolic diseases like diabetes, hypertension, coronary artery disease, left ventricular dysfunction, they contribute to atrial fibrillation to a majority of cases in Western world and to a great number of cases in our scenario too. Male gender, advancing age as we have already seen, and hyperthyroidism are known to be associated more with atrial fibrillation. It is important to identify any congenital or structural heart disease underlying, particularly those which involve the dilatation of left or right atria. Cardiomyopathy, either obstructive or dilated or hypertrophic type, can result in atrial fibrillation. Excessive alcohol use is associated with atrial fibrillation. This is called holiday heart because they have lot of drink over the weekend and they come out with atrial fibrillation at the end of the weekend. Use of illicit drugs which are cardiostimulatory can result in atrial fibrillation. Acute pulmonary problems like acute pulmonary edema, acute pulmonary embolism, sometimes cardiac surgery, usually when a patient undergoes bypass surgery or any other cardiac surgery for that matter, on the second or third postoperative day, significant proportion of the patients do develop atrial fibrillation. These are some of the causes, common causes of atrial fibrillation. Remember, rheumatic valvular heart disease is the forerunner, followed by the cardiometabolic diseases like diabetes, hypertension, coronary artery disease, LV dysfunction, and the other things follow. What are the factors which cause the atria to fibrillate? We have the different diseases which cause atrial fibrillation. What exactly is the mechanism by which the atria are thrown into atrial fibrillation? There is what is called hemodynamic stress. There is an increase in the intra-atrial pressure. How? Either due to mitral or tricuspid valve disease, due to mitral or tricuspid stenosis or regurgitation, the intra-atrial pressure increases, atrial size increases, or there could be LV dysfunction which in turn can increase the intra-atrial pressure. Systemic or pulmonary hypertension can result in increased pressure in the ventricles, which could again result in increased pressure in the atria. The second theory is the atrial ischemia. First theory is the hemodynamic stress, that is increased intra-atrial pressure. The second one is the atrial ischemia due to coronary artery disease or ventricular ischemia producing and leading to increased left atrial pressure. Sick sinus syndrome, inflammation, drug use, alcohol, endocrine diseases like hyperthyroidism, neurologic diseases like subarachnoid hemorrhage and stroke can result in atrial fibrillation. There is one variety of atrial fibrillation called familial atrial fibrillation, though not very common. Cardiac surgery and certain collagen diseases do also cause rarely atrial fibrillation. Commonly, atrial fibrillation is associated with a structural heart disease. The structural heart disease could be a rheumatic heart disease or hypertensive heart disease or a cardiomyopathy, obstructive, dilated or congenital heart disease or coronary artery disease itself. Elevated B-natriuretic peptide suggests underlying heart disease. Atrial fibrillation without concomitant structural heart disease can also occur, particularly in the young, and such cases of atrial fibrillation without any underlying concomitant structural heart disease are dubbed as or termed as lone atrial fibrillation. That is atrial fibrillation in the young patients without any structural heart disease with lower risk of thromboembolism. Another thing that we would see with atrial fibrillation is hemodynamic instability. What is hemodynamic instability? It is in the form of severe dyspnea reduced oxygen saturation in the pulse oximetry, fall of blood pressure, hypotension, severe chest pain, and patient may end up in shock. This is an emergency. Atrial fibrillation presenting with hemodynamic instability should be immediately attended to by cardioversion. Suppose the patient is hemodynamically stable, then the management is much simpler. Let us look at some of the investigations that we need in a case of atrial fibrillation. It is mandatory to have a 12-lead ECG with a rhythm strip. What do we look at in the ECG? Look for pre-excitation, that is the WPW. If there is pre-excitation, it warns us of a grave danger. Determine the heart rate. Is it more than 200 or is it around 100 to 150 or is there bradycardia? Evaluate the status of the left ventricle. Look for bundle branch blocks. Look for previous myocardial infarction. QT interval and QRS intervals for patients on antiarrhythmic drugs, because antiarrhythmic drugs are notoriously known to affect the QT interval very much and also sometimes the QR interval. These have to be properly measured and assessed in a ECG of atrial fibrillation. The other test, of course, is a 6-minute walk test, also known as exercise test, or we can do a small treadmill test also. This is to assess the effectiveness or efficacy of rate control measures that we use. So, normally the target heart rate should be around 80 at rest and should not go more than 110 with 6-minute walk. Holter monitoring is required in some cases where the atrial fibrillation is paroxysmal. Electrophysiology only in selected cases. We do not require EP mapping and electrophysiological studies in all cases of atrial fibrillation. Echocardiography is mandatory. This is to assess 3 or 4 important features, particularly the atria, the atrial size, the left ventricular size, the presence of atrial clot, and presence of underlying structural heart disease, valvular heart disease, and of course the cardiac contractile ability, the ejection fraction, and things like that. Transthoracic echocardiography is normally enough. But in cases where we want to study the atria, particularly look for the clot or thrombus in the atria, we may require transesophageal echocardiography, also known as TEE. X-ray chest is required to evaluate any pulmonary disease which is associated and which may be the underlying cause for the dyspnea and not the atrial fibrillation, or sometimes the pulmonary disease may be the cause for the right atrial pressure and right atrial dilatation producing atrial fibrillation. We require thyroid function tests and renal function tests and of course serum electrolytes, because we know electrolyte abnormalities and hyperthyroidism are associated with atrial fibrillation. What are the conditions which we need to differentiate from atrial fibrillation? Atrial flutter. Of course, there is a systematic conduction of the atrial impulse with 1:2 or 1:3 ratio, and the heart rate is very regular, and usually it is a tachyarrhythmia. Atrial tachycardia, AV nodal reentrant tachycardia, atrioventricular nodal reentrant tachycardia, or AVNRT, or PSVT, paroxysmal supraventricular tachycardias, WPW syndrome, digoxin toxicity, cardiac ischemia secondary to rapid ventricular rate, hyperthyroidism, and pulmonary disease, all of them can mimic atrial fibrillation, and we require to exclude these conditions before we confirm the diagnosis of atrial fibrillation.